It's 2 in the morning, right? And your toddler wakes up, but instead of a normal cry, they make this harsh, just terrifying sound.
Oh, yeah, like a barking seal echoing down the hallway.
Exactly. And your immediate primal instinct as a parent, or, even as a newly minted doctor, is to just look down their throat to see what's blocking their air.
Which makes total sense. I mean, you want to see the problem.
Right. But depending on what is actually causing that sound, the sources say simply opening their mouth and looking inside could trigger a reaction that, well, stops their breathing entirely.
Yeah, it literally stops it. That split-second decision in the dark is the harsh reality of pediatric emergency medicine.
It's just terrifying to even think about.
It is, because a child struggling to breathe isn't just a stressful scenario. It is a highly precarious physics problem. And for centuries, we just didn't fully understand the physics or, the biology of what was happening inside those tiny airways.
So today, our mission is to decode 2 classic, really nerve-wracking airway emergencies, croup and epiglottitis.
2 very distinct, very dangerous conditions.
Right. And we are pulling from clinical nursing guidelines, pediatric triage protocols, and some historical medical texts for this deep dive to figure out basically how to tell these 2 apart.
And why getting it wrong can be catastrophic.
Exactly. We're going to explore how one of these diseases forces you to just abandon your most basic medical instincts, and then how the other was practically erased from pediatric wards by a single scientific breakthrough.
It really is a fascinating journey.
It is. Ultimately, this deep dive is going to completely change how you view a simple sore throat. So, where do we start?
Well, to understand the danger, you really have to visualize the anatomy first. Both of these conditions share a fundamental vulnerability, which is the sheer physics of a child's airway.
Because it's so small, right?
Right. A smaller tube naturally moves less air, but the relationship is governed by Poiseuille's law for laminar flow.
Okay, Poiseuille's law. What does that actually mean for the kid?
It means airway resistance doesn't just increase proportionally as a tube gets smaller. It rises with the 4th power of the radius.
Wait, the 4th power. So if the airway radius gets just a tiny bit smaller, the resistance doesn't go up a little, it just skyrockets.
Exactly. It skyrockets. If you cut the radius of a breathing tube in half, the resistance to airflow doesn't double. It increases 16-fold.
Oh, wow. 16 times harder to breathe.
Yeah. Now apply that math to a toddler. Their baseline airway is roughly the width of a pencil.
Just a pencil. That's so tiny to begin with.
Right. So a mere 1 millimeter reduction from inflammatory swelling causes a catastrophic drop in airflow. I mean, an adult wouldn't even register a single millimeter of swelling in their throat.
They just think, oh, I have a slightly scratchy throat.
Exactly.
Yeah.
But for an infant, it brings them to the brink of total obstruction.
I was picturing it kind of like city infrastructure while reading the sources. Like, if you have a massive underground water main, a 1 millimeter buildup of rust on the inside isn't going to change the water pressure for the neighborhood at all.
No, not even slightly.
But if you have that exact same 1 millimeter buildup of rust inside a tiny garden hose, the water just stops flowing completely.
That's a perfect analogy. The scale of the anatomy completely dictates the danger here.
So since both diseases deal with this garden hose physics problem, the difference must come down to where that 1 millimeter of swelling actually is.
Precisely. Location changes absolutely everything. So croup, which is formally called laryngotracheobronchitis.
There's a mouthful.
It is, yeah. But croup is a viral inflammation, and the swelling happens just below the vocal cords, so in the subglottic space.
Okay, below the cord.
Right. Now, epiglottitis is anatomically distinct. The texts sometimes call it supraglottitis because the swelling sits directly above the airway opening.
Ah, okay, so above versus below.
Yes. And historically, epiglottitis was almost always a bacterial infection targeting the epiglottis, which is that tiny leaf-shaped flap of cartilage that, folds down to protect your windpipe when you swallow.
So below the cords for croup, above the cords for epiglottitis, that tiny anatomical shift, like literally just a few millimeters of difference in the throat, creates wildly different sounds when a child actually arrives in an emergency room.
Right, it really does. Croup has that distinct auditory signature we mentioned at the start.
The harsh, barking cough. The sources universally compare it to a barking seal.
Yeah, the seal bark is classic. But the real hallmark sound of croup is stridor.
Stridor, that's the high-pitched one, right?
Right. It's a high-pitched crowing noise that you hear when the child breathes in. You are literally hearing turbulent airflow violently struggling to pull through that narrowed subglottic passage.
It sounds exhausting for the kid.
It is. And fun fact, the word croup actually derives from an old Scottish dialect verb, roop.
Roop. What does that mean?
It means to shout or cry out hoarsely.
Oh, wow. So it's a disease literally named after the forceful sound it produces. But epiglottitis doesn't have that loud, chaotic bark, does it?
No, it doesn't. And honestly, it is often eerily quiet, which is much, much more alarming to clinicians.
Quiet is bad.
Very bad. Clinicians are taught to look for the 3Ds when it comes to epiglottitis: drooling, dysphagia, and distress.
Dysphagia, meaning difficulty swallowing.
Exactly. The child isn't barking because they are dedicating every single ounce of their energy just to pull oxygen past that swollen flap of cartilage.
And the drooling happens because the airway is so swollen and it hurts so much to swallow that they can't even clear their own saliva.
Right. They just let it spill out.
While reading the clinical sources for this deep dive, I noticed a very specific physical posture these kids adopt too. It's called the tripod position.
Oh, yes. The tripod position is a huge red flag.
Yeah, they sit up, lean forward, put their hands on their knees, jut their chin out, and just open their mouth. And I was thinking, no one teaches a 2-year-old to do this.
No, it's entirely instinctive.
Wow.
It is an unconscious biological drive to manually align their internal anatomy. They are trying to force open whatever tiny airway diameter they have left.
It's like a primal survival reflex.
Exactly. And recognizing that tripod posture brings us to really a foundational rule in nursing and medical education.
A golden rule.
Yes, if you see a child in that posture, drooling, visibly working for air, you must never attempt to visualize the throat with a tongue depressor.
See, I had to read that line in the guidelines twice. Because if someone says their throat hurts and they can't breathe, the most universal medical instinct is to say, open your mouth, let me look.
Of course it is.
But the guidelines treat a tongue depressor like it's a loaded weapon. How does just looking at a throat kill a patient?
It comes down to the evolutionary purpose of the larynx. I mean, its primary job isn't actually speech. It's to act as a security door, preventing food or water from getting into the lungs.
Okay, so a biological bouncer.
Exactly. And when the epiglottis is massively infected and inflamed, that biological tripwire is hypersensitive.
So any touch sets it off.
Any mechanical stimulation, just the physical touch of a wooden stick, or even the child panicking because you're forcing them onto their back to look in their mouth, it makes the brain think it's choking.
Oh, I see.
So it triggers a laryngospasm. The muscles violently slam the security door shut. And because the airway is already critically narrowed by the disease, that spasm just seals it off entirely.
Wow.
Yeah, in seconds, a child who is struggling to breathe becomes a child who cannot breathe at all.
So you literally have a patient suffocating in front of you, and your medical protocol is to touch absolutely nothing.
Nothing. You keep the child calm. You let them sit right in their parent's lap in whatever posture they choose.
No IVs or anything.
No 5E lines, no blood draws, absolutely no laying them flat. Simultaneously, you are urgently calling for anesthesia and an ear, nose, and throat specialist to secure the airway in the operating room.
Why the operating room specifically?
Because they need an environment where they have specialized surgical tools to bypass the throat entirely if that airway completely closes. They might need to do an emergency tracheotomy.
It's wild that we know to do this now. I mean, the precision we have today, knowing exactly when to intervene and when to keep our hands in our pockets, it's built on a long foundation of historical trial and error.
Oh, absolutely. A lot of tragic error, unfortunately.
Yeah. I mean, if we go back to 1765 in the texts, Francis Home, a physician in Edinburgh, published an inquiry trying to define croup. But doctors back then were basically treating all childhood throat illnesses as one giant, undifferentiated soup of respiratory deaths.
Right. And the devastating failure of that era was lumping viral croup together with diphtheria.
Diphtheria, which is totally a different.
Completely different pathogen. Diphtheria is a highly lethal bacterium that creates this thick, grayish, leathery pseudomembrane in the throat.
A membrane that physically grows across the airway.
Yes. It physically grows and literally chokes the patient from the inside.
So a bacterial membrane essentially acting as a cork.
Precisely. And because physicians couldn't easily differentiate the two, they treated the viral, usually self-limiting croup with the exact same aggressive panic as diphtheria.
Which meant what, practically?
It meant they subjected children with viral croup to futile, agonizing remedies. Leeching, harsh emetics to induce vomiting, even early tracheotomies in unsterile conditions.
All because they believed a fatal membrane was forming when it wasn't.
Right. It wasn't until the 1880s, when the diphtheria bacterium was actually isolated under a microscope, that pediatricians could confidently separate the viral illness we call croup from the bacterial nightmare of diphtheria.
And untangling those diseases allowed doctors to finally figure out what actually works for croup.
Yes, finally.
And the modern treatment involves a massive contradiction to typical medical advice, which I found fascinating. Usually, if you have a sick child with a fever and a terrible cough, the absolute last thing you do is take them out into the freezing winter air.
Right, you want to keep them warm.
Yeah. But parents historically would bundle up their barking toddler, run out to the car on a cold November night, and by the time they actually reached the ER triage desk, the kid was breathing easier.
Because the cold air wasn't just a placebo, it acts on the fundamental biology of the subglottic tissue.
How so?
The cold night air triggers reflex vasoconstriction. So, the blood vessels in the inflamed mucosa rapidly shrink in response to the temperature drop.
And shrinking blood vessels means less swelling.
Exactly. When the blood vessels shrink, the physical swelling in the tissue goes down, which pulls a child away from that catastrophic 16-fold increase in airway resistance we talked about.
That's incredible. So it's one of the rare instances where stepping outside into the cold is a scientifically sound first aid measure.
It really is. It works.
But if cold air actively constricts the blood vessels, what about the other classic home remedy? The cool mist humidifier. I mean, it feels like every nursery has one of those elephant-shaped humidifiers pumping mist into the room.
Oh, the cool mist humidifiers. They've reached a near universal folk status. But they are a perfect example of a treatment persisting simply because it feels intuitively helpful.
Wait, they don't work.
When subjected to controlled clinical trials, the evidence for mist therapy altering the course of croup is remarkably weak.
Really? So people are just filling their rooms with steam for no reason?
Well, it might soothe the dry throat, sure, but it does not effectively shrink subglottic edema. The swelling stays the same.
Okay, so if mist doesn't shrink the swelling, what does? I mean, we obviously can't just leave a toddler out in the winter air all night long.
No, definitely not. The paradigm shifted significantly following a 2004 study published in the New England Journal of Medicine by Bjornson and colleagues.
What did they find?
They demonstrated that children with even mild croup benefited from a single dose of oral dexamethasone.
Dexamethasone, that's a corticosteroid, right? To forcefully shut down the inflammation?
Exactly, and just one dose. It drastically reduced return visits to the emergency room and severely shortened the duration of symptoms.
Just one dose did all that.
Just one. The data was so conclusive that dexamethasone became the absolute standard of care across the board. You no longer just tell parents to take the kid home and wait it out.
And what if it's really bad? Like a severe case?
For moderate to severe cases, clinicians use the Wesley Croup score to assess the patient, and they might add nebulized racemic epinephrine.
Epinephrine. That's essentially adrenaline, right?
It is, yeah. Inhaling it acts almost like a chemical version of the freezing night air. It causes rapid, intense vasoconstriction of the airway tissue.
Okay, so it shrinks everything down quickly.
Very quickly. It buys hours of immediate improvement. Though the child does require careful observation because, well, the swelling can rebound once the medication wears off.
So science isolated croup, figured out the cold air mechanics, and standardized the steroid treatment. But epiglottitis didn't just get a better treatment protocol, did it? The entire disease was practically erased from childhood.
It was. The modern history of epiglottitis is honestly one of the most stunning victories in public health.
How bad was it before?
Before the mid-1980s, epiglottitis was a constant, terrifying staple of pediatric emergency training. The primary culprit was a specific bacterium, Haemophilus influenza type B.
Commonly known as Hib.
Yes, Hib.
And the sources detail how this specific bacteria wasn't just causing airway swelling either. It was invading the bloodstream and causing devastating meningitis in young children.
It was awful. It was a leading cause of acquired mental disability and pediatric mortality. But then, in 1987, the Hib conjugate vaccine was licensed and added to the routine childhood immunization schedule in the U.S.
And what happened?
What followed was just a breathtaking natural experiment. Within a decade, invasive Hib disease, including the classic pediatric epiglottitis, plummeted by over 99% in vaccinated populations.
A 99% drop. I mean, we aren't talking about a gradual decline over a century due to, like, better hand washing or sanitation.
No, not at all.
A common, highly lethal disease basically fell off a cliff the exact moment a targeted vaccine was introduced.
The pediatric wards emptied of these specific cases almost overnight. The clinical texts frame this as an irrefutable case study of vaccine success.
It's an amazing medical triumph. But here's where it gets really interesting, based on the texts. Because the incredible efficacy of the Hep vaccine created a profound, totally unexpected shift in demographics.
Yes, it did. Epiglottitis didn't vanish from the planet entirely. It just shifted populations.
You adults, right?
Exactly.
Yeah.
Today, epiglottitis is proportionally more common in adults than it is in children.
I guess because adults' airways are so much wider, the swelling isn't as immediately catastrophic, but they are still actually getting the infection.
They are getting it, yes. But it is usually driven by entirely different organisms now, like Streptococcus species. And the onset in adults is often slower, more insidious.
Which creates a new problem.
A huge problem. This demographic flip creates a massive cognitive trap in modern medicine.
How so?
Well, you have a whole generation of pediatric trainees who might complete their entire residency without ever seeing a true case of Hib epiglottitis. Concurrently, you have adult ER physicians who might evaluate a 40-year-old patient presenting with a fever, severe sore throat, and difficulty swallowing.
And they don't even think of epiglottitis.
Exactly. The doctor might completely dismiss the possibility because medical folklore has firmly anchored it in their mind as a childhood disease.
That is a very dangerous blind spot.
Mm-hmm.
If a doctor assumes a disease only exists in textbooks or pediatric wards, they just won't look for it in the adult sitting right in front of them.
Which delays treatment and increases risk.
That makes me wonder about the flip side of that triage coin, too.
Yeah.
Like, if you are an ER nurse or doctor today, and a child comes in with that high-pitched stridor, is there a risk of just anchoring on croup?
Oh, absolutely.
Like, if you hear the seal bark, do you just hand them a dose of dexamethasone and assume they're fine?
Anchoring on croup is one of the most perilous mistakes a clinician can make, actually. There is a very pervasive misconception that stridor in a child equates exclusively to croup.
But it doesn't.
No. Stridor is just a physical symptom of turbulent air passing through a narrowed tube. It is a sign of obstruction.
Right, the physics problem again.
Exactly. That obstruction could be viral croup, but it could also be a swallowed coin lodged in the upper airway, a deep retropharyngeal abscess, or, most alarmingly, bacterial tracheitis.
Bacterial tracheitis. The medical texts refer to this as the great mimicker.
It is the ultimate diagnostic camellia. It occupies this really dangerous gray zone between viral croup and bacterial epiglottitis.
Why is it so tricky to spot?
Because initially, bacterial tracheitis presents exactly like a severe case of croup. The child has the bark, the stridor, the struggle for air. Everything looks like croup.
Okay, so you treat it like croup.
Right. You administer the racemic epinephrine, you give the dexamethasone, but then the trajectory diverges. The child continues to deteriorate.
I noticed the sources use terms like toxic appearing for these kids.
Yes, they aren't just dealing with the swollen throat anymore, they are dealing with a severe systemic infection.
So they look much sicker.
Much sicker. They will spike high fevers. They might exhibit cyanosis, meaning they are actually turning blue around the lips from a lack of oxygen. You'll see severe retractions, which is when the child is pulling in their chest muscles between their ribs just to forcefully vacuum air into their lungs.
So the steroids aren't working because it's not just regular swelling.
Correct. The obstruction in tracheitis isn't just inflamed tissue. The trachea becomes physically blocked by thick, purulent secretions, so heavy, pus-filled mucus that steroids simply cannot dissolve.
Wow. So if you hit that clinical wall where the standard croup treatments are just failing, you have to immediately widen your differential diagnosis. You can't just keep giving them epinephrine and hoping the physics improve.
You can't. And historically, before we had advanced imaging and rapid lab tests, X-rays were a crucial tool for cutting through this diagnostic fog, assuming the patient was even stable enough to be imaged.
What were they looking for on the X-rays?
Clinicians learned to read specific shadows on lateral neck X-rays. For croup, they look for the steeple sign.
The steeple sign, like a church.
Exactly like a church steeple. The narrowing of the subglottic space physically tapers on the film, looking exactly like a pointed tip.
Okay, and for epiglottitis?
They look for the thumbprint sign.
Thumbprint.
Yeah, the epiglottis is so massively engorged and rounded that the shadow on the X-ray looks like someone firmly pressed their thumb right into the middle of the airway.
The steeple and the thumbprint. I mean, those radiographic markers provide such clear visual anchors.
They do, but even with imaging, bacterial tracheitis confounds the picture.
Really? Even with X-rays?
Yes. An X-ray might show a steeple sign, misleading you into thinking it's just simple croup, while a lethal bacterial infection is brewing in the trachea.
So you can't just rely on the picture.
Never. The physical presentation of the patient must always override the assumptions of the initial triage or the X-ray.
It is such a dynamic, high-stakes environment. You really cannot practice emergency pediatrics by following a flowchart blindfolded. You have to treat the physics in front of you.
Absolutely.
Well, we've covered a lot of ground today. We started this deep dive exploring the unforgiving math of a child's tiny airway, where a single millimeter of swelling dictates whether oxygen reaches the lungs.
And we uncovered the evolutionary tripwire behind the strict do not look rule of epiglottitis, where a single wooden tongue depressor can trigger a fatal laryngospasm.
Right. We also mapped the historical struggle. Differentiating viral croup from the suffocating pseudomembrane of diphtheria literally changed the trajectory of pediatric care.
It allowed us to finally abandon invasive, futile treatments in favor of scientifically validated interventions, like the cold air effect and targeted corticosteroids.
And we explored the absolute, undisputed triumph of the Hib conjugate vaccine. It didn't just mitigate a disease, it virtually eliminated a terrifying pediatric airway emergency, proving that human intervention can fundamentally alter the landscape of infectious disease.
The practical application of this knowledge is immense. Rapidly distinguishing a manageable barking cough from a true life-threatening airway obstruction is a vital skill for anyone involved in pediatric care.
Absolutely.
But beyond the clinical mechanics, epiglottitis serves as a definitive case study. As the texts point out, in an era grappling with resurgent vaccine hesitancy, this is not theoretical data. We are talking about a deadly pathogen that used to regularly fill hospital wards and is now a clinical rarity purely because of widespread immunization.
Which leaves a lingering question for you to consider long after this deep dive ends. We saw how the success of the Hib vaccine essentially evicted epiglottitis from the pediatric population. It forced the disease profile to shift into adults, now driven by entirely different bacterial organisms like Streptococcus.
A total ecological shift.
Right. So as we continue to develop new vaccines and alter the baseline immunity of global populations, what other supposedly classic childhood diseases are quietly mutating or shifting right now?
It's a sobering thought.
It is. What other pathogens are finding new footholds in adult populations simply because we have permanently disrupted their original pediatric ecology? The human body and the microbes that attack it are always adapting.
And the diagnostic waters are never perfectly clear. We have to adapt right along with them.